Now, what's the difference between the light you're looking at your lamp above your head or the laser light? Now, if you look on the right side, laser light is coherent, white light is non-coherent. That means laser light is a one wavelength, whereas white light is a mixture of all the wavelengths. Again, laser is monochromatic, meaning that laser is one color of light only. You all know that the white light is a mixture of a lot of colors. We call that the visible spectrum. The third difference is white light goes in a fan-shaped form in several directions, whereas the laser light is collimated. So it's basically bundled and centered. Laser is usually emitted from a energized material, which is a semiconductor, usually a crystal, a gas, or a dye. Now, the key of laser application is its interaction with the tissue. Now, the interaction is threefold. Laser energy is absorbed by the tissue, but some of it is reflected by the tissue, and some of it is scattered in various directions or transmitted, meaning it comes out on the other end of the target organ. The absorption is the most important component. The energy that is absorbed by the target is the energy that we use to get the desired effect. And the desired effect happens by converting light to thermal energy, heat basically. And that in turn results in either coagulation or vaporization of fluid. So the absorption determines the surgical effect. Reflected light is lost. Transmitted light, which goes through the organ and comes out at the other end, is lost. And scattered light, which is going in all directions, is lost as well. And keep in mind that reflected, transmitted, or scattered light is a risk factor because we don't know where this laser energy goes. It goes not right into the target, it goes somewhere around it. So if that is too much, it may inflict collateral damage. Now, this is the electromagnetic spectrum in nanometers, and you see there in gray on the right side the Holmium-Yack laser, which is our working horse at the moment, and that is at a wavelength of 2,100 nanometers. Now, the new kid on the block, the Thulmium laser, is very close to this with 1940 nanometer, and you can imagine that therefore it might have a kind of similar effect on the target, which in our case here for this talk is the stones, and both of them are in the infrared spectrum. Now, the Holmium-Yack laser is without doubt today the most used laser lithotripter. Its energy is released in a pulsed fashion, and it travels along the laser fibers through internal reflection. That is why you have this blue or green mantle around the laser fiber. So the laser, of course, doesn't come out as one beam, although it is collimated, but still the photons, they travel in one direction, but they bounce off the mantle and come out at the end in a straight fashion. Wavelengths, we said already, is 2,100 nanometers. There's a very high absorption in water, which means it must be in contact or close contact with the target. The penetration depth in tissue is only 0.5 millimeter. That means if you're more than 1 millimeter from the target in a fluid environment, then nothing should happen. Now, there is a term called nominal ocular hazard distance. That means how far can you be away from the laser if it shines into your eye in air without damaging your retina, and that is 1.1 meters. So if the laser fiber breaks on the table or in the instrument or wherever, if you are within 1.1 meters of any point of the laser fiber or the outlet of the laser machine, you are bound to wear laser goggles to protect your retina, but we're coming to that later in the safety section. So the holmium laser works mainly thermal, as I said. It's a conversion from light into heat. Actually, the energy, the heat, creates a cavitation bubble in superheated water. Now, for those who know a little bit about shockwave lithotripsy, it's a similar kind of effect. Shockwave lithotripsy also creates a micro bubble. This bubble then implodes. It doesn't explode, it implodes and creates a shockwave. And this shockwave then disrupts the stone on its stress lines. So in a funny way, shockwave lithotripsy and laser is both working with shockwaves, but through different mechanisms. So as I said before, the penetration depth is 0.5, so half a millimeter. So if you are, for example, like in the upper picture, 5 millimeter away from the tissue, nothing will happen. The whole laser energy will be absorbed by the target tissue. Now for stones, that means you need to be close to the stone, between 0 to half a millimeter. You need to leave ideally a little bit of a gap, less than half a millimeter, because you want to create that bubble in the superheated water for the shock wave. Now, if you want to have some effect in the soft tissue deeper than these 5 millimeters, you have to go a bit closer, as you see at the bottom on the left, to coagulate and stop the blood, the bleeding. If you want to use the laser, the holmium laser, for cutting, then you have to have a contact with the soft tissue. Now, one of the problems of laser, for all those who are familiar with it, is the retropulsion. So the stone moves quite a bit when we laser and may go away from us, and then we might not find it anymore. So that is a little bit of a problem. So some lasers have the so-called Moses effect. That means the laser is not released at one energy at a time, but in two portions. The first energy induces a cavitation bubble, or they call it a vapor channel. And the second laser comes milliseconds after that and goes through this vacuum channel, if you want so, and comes therefore, without being partially absorbed by the water in between, directly onto the stone. So there's much more temperature on the stone, and that actually, in addition to the shockwave bubble, leads to a chemical breakdown of the stone. So you have a double effect of the breaking. So this video may demonstrate that a little bit. So there's this channel created, and the laser works inside the channel. So hopefully we get less propulsion with that. Now, everybody talks about the new kid on the block, the Trillium laser. Now, it is said that it has a 4 times higher absorption coefficient in water than holmium. It has certainly a smaller fiber diameter. So where we're using in the holmium laser fibers of 250, 400, and roughly 600 micrometers, the Trillium laser can use fibers of 50 to 100 micrometers. It has much lower energy per pulse, and we're coming to the energy settings later, from 0.025 joules, and a much higher pulse rate, up to 2000 hertz. So it should have a higher ablation efficiency than holmium, and because the fibers are so much thinner, we would get a better bending and better irrigation in our flexible ureteroscopes. All in all, it's set to save time, but certainly at this point in time, it doesn't save you money because it's very expensive still, as with all new technologies. Now, let's talk about laser energy. Now, the amount of energy depends on the pulse energy and the frequency. You all know, or those who use the laser, that we play with the joules and the hertz. So the total power or the total energy is measured in watt, and that is joule times hertz, so energy times frequency. And then we have three modes of laser settings. We have the dusting, the fragmenting, and what people call the helicoptering or popcorning. Now, typically for fragmenting, so if you want to have larger fragments, you use high energy and low frequency. And as an example, for a 20-watt holmium laser, I have here put 1.2 joule and 6 hertz, and you get a total energy of 7.2. Now, if you want to dust a stone, then you need a low energy and a high frequency. So typically I've put here 0.6 joule, so half of the joule, but double of the frequency, 12 hertz. And mathematically, you get the same energy output, but you get a different effect. If you want to popcorn these stones, then you need to apply a high energy and a high frequency. For example, 1.2 joules and 10 hertz. So 12 watts is the output, and that is, of course, then higher. Now we're coming to settings, laser settings. There we have one additional factor, that's the pulse width. So newer holmium lasers have the option to alter the width of each separate pulse. So you can combine not only frequency and energy, but you can also combine with it the pulse width. And that again has a different effect on stone fragmentation. And it has consequences on the efficacy of your laser fibers, as I will show later. Now, the pulse width is the time duration of a single pulse in microseconds. First generation holmium lasers had a fixed mode of about 350 microseconds per pulse. The newer systems have a range of pulses between 500 and 1,500 microseconds. Now, does that make a difference? Up to a total energy of 10 watts, there's not really a difference between short pulse and long pulse. But if the energy is increased, then the short pulse takes much longer to fragment stones. Now, what's the difference between the two? Now, in the short pulse mode, there is much more retropulsion, up to 50% more. The long pulse mode is protective for the laser fiber. The laser fiber, for those who have seen or used lasers, you know after some time the laser fiber breaks at the end, the blue mantle comes off, the laser fiber becomes shorter, and the light is not so centered anymore. We call that a burn back. And that reduces the energy output and the efficiency of the laser, or of the fiber rather. So if you have a setting with a lower energy and a long pulse, that reduces the burn back of the laser fiber. Now I will demonstrate the effect of short and long pulse. This is the same stone, long pulse mode, with a 200 micrometer laser fiber. You see that the stone stays more or less in place in a wide renal pelvis, which sometimes is a problem because it starts moving around. And now we have switched to a short pulse, and you see clearly it breaks into big fragments, but the stone fragments start dancing around. That is the propulsion. Now, for the big fragments, we are back into long pulse mode. So they stay in place. So this illustrates nicely the effect of long and short pulse in the laser. Now, let's come to the next one, which is the pulse energy. Now, the pulse energy can range from 0.2 to 6 joule, but usually for typical 20 to 30 watt laser, it would reach between 0.5 and 1.2 joule if you use a flexible instrument with a 200 micron fiber, because if you ramp up the energy too high, the laser fiber may break, and then with it your expensive instrument. Now on the left side, you see this table. It does show that fragmentation is increased with energy. There is no doubt about that. You get a greater loss in stone mass over time. But when you ramp up your energy, you get larger fragments as well. So the pros of a higher energy setting is larger fragments. That's fine if you are a basketer and you're prepared to basket these fragments out with, say, a ureteric access sheath. Now, if you are a duster like myself, I use very rarely baskets, only to get samples for stone analysis. Then a high energy will anger you with retropulsion, inefficient lithotripsy, and an increase in surgery time. Now, the last parameter is the pulse frequency. That is the number of pulses per second measured in hertz. So usually a 20 watt laser would be limited to 15 to 20 hertz maximum. But if you have more energy lasers, like a 100 watt laser, it could be up to 50 hertz. Now, increasing the frequency may also increase the retropulsion, but not to the same degree as the energy. So if you want to increase your energy in a stone that is likely to jump away out of your view, always increase the frequency first, not the energy, because the frequency doesn't have this strong retropulsive effect. Now, if you have a high frequency and a low energy, we call that dusting. That results in fragments smaller than 1 millimeter. Now, I'm sure after this kind of dry talk about the settings, you are utterly confused. So to make it easy, some lasers give you a kind of foolproof menu where you just choose between soft, medium, hard, and super hard. So that takes the headache away from calculating the energies yourself. So a good way to approach a stone is to measure the Hounsfield units in a CT scan, so you know already a little bit how hard will be the stone. And then when you start lasering the stone, you do what we call a contact lithotripsy. So you break the stone either into fragments or dust, depending on if you are a basketer or duster. And then when they're small enough, you, at the final stage, pulverize the fragments as much as possible in a confined compartment, which could be a calyx. So the stones or whatever is left of the stone is of a size where it can be spontaneously washed out. Now we're coming to laser fibers, and there are some often asked questions. So people ask me, is there a difference between small and large fibers on stone fragmentation? Well, you can note a difference when you apply a higher energy. But of course, if you work with a flexible scope, you're limited to the thinner laser fibers, so you wouldn't reach these high energies. But certainly for people who have used 600 micron or 800 micron fibers for a bladder stone, through a cystoscope or through a nephroscope in the bladder, will vouch for it that the energy can be ramped up and be more efficient for these kind of big stones. Does fiber size impact the size of fragments? Now, there was an interesting paper, it's almost 20 years old, where they looked at hard stones, calcium oxalate monohydrate, and used a set energy of 0.5 joules, so not a very high energy, with a 365 micron fiber, and they got 29% fragments larger than 2 millimeters at the end. If they used a smaller fiber, 270 micron, with the same setting, they got 4% of fragments more than 2 millimeters. So the conclusion is, if you have a smaller fiber, you get smaller fragments. Now, does the fiber size influence scope flexibility and irrigation flow? Definitely it does. I think most of us have seen these pictures where, depending on what is in your flexible scope, the angle of deflection goes considerably down. And this picture shows, on the left, you see an empty scope and two empty scopes. One is black, one is white, where the irrigation flow is measured. And when you look at the third one from the left, the holmium YAG laser is inserted. The irrigation flow goes already down with the 200 micron fiber by about 30%. If you put a basket in, like a zero tip or grass pit, then you almost have no irrigation flow left. So the thinner the fiber, the better moves your instrument, and the more irrigation you have, the better your irrigation, the better your view. Now, does the state of fiber impact the power output? Now, we talked a little bit about the burn back. And if you have less burn back, you get more efficiency and power output for longer. Now, there's a lot of discussion going on about the cleaving method. The companies sell very expensive cleavers to cut the laser fiber. Some people use a scalpel, some people use ceramic scissors, and especially Traxa had shown not very long ago in 2019 that it doesn't make a difference. It may make a difference for the first 3 to 5 shots, but after that, however you cut your laser fiber, you will have the same result. Now, there's a debate going on, stripped or unstripped laser fiber. On the left, you see stripped laser fibers. That means that the mantle of the laser fiber is cut back and the laser fiber is exposed at the end, the glass fiber. Again, Traxa found that an unstripped laser fiber without the transparent end is more efficient. That may have to do with the fact that some of the laser energy will go astray from the transparent tip. Personally, I do use only unstripped fibers, and the reason for that is that if the going gets tough and the view is impaired, you may not be able to see the transparent tip, but you might be able to see the blue tip of your laser fiber. And that may help if it's bleeding or if there's too much dust on lasering and your view is not very good. Now, so you have choices. You must make choices. You must make the choice between a reusable versus a single-use fiber. You must make the choice between a 200 versus a 360 micron fiber when you do ureteroscopy. And of course, there are added benefits in the form of contracts, service contracts, fibers come with the machine, and so on. Considerations are, of course, the costs, but I like to admonish you, think scope, don't think fiber. If you buy a cheap fiber and put it into an expensive scope, you may find that the cheap fiber damages your expensive scope and you pay at the end much more. Other considerations are the proper training of staff that helps you and of yourself, of course. Stone location, the reposition of the stone, for example, from the lower pole into the upper pole. Now, you imagine a laser fiber with a mantle. The laser particles bounce along inside the fiber and come out at the end. Now, if you bend your laser fiber, that means that all the laser particles will hit this high point of the laser fiber. So there is a concentration of energy at this point. So if you work in the lower pole with a bent scope for a long time, this is a likely point for breakage. Now, if you look at these pictures, these are electromagnetic pictures of a laser fiber cut with a proper industry-provided laser cutter. And you would think you should have a plane surface. Well, you don't. And actually what you have on the left side is a razor sharp edge. So any unpolished sharp fiber tip has the potential to damage your scope lumen. On the other hand, once the scope lumen is damaged, if you introduce your laser fiber, it may get trapped in that damage and the laser fiber gets further damaged. Usually this happens during cleavage of reusable fibers. So there is a strong argument for disposable fibers, but it may not be always financially viable. If you have a damaged fiber, it scatters the energy, and as we have heard before, scattered energy can go anywhere and we don't know what damage it inflicts and where. Now we're coming to the techniques of applying the laser on the stone itself. The first technique is the so-called dancing technique. This is used for soft stones. The tip of the fiber is brushed back and forth across the stone surface, and this is then ablated layer by layer at a low speed with a constant motion. This is what other people also call a dusting technique. You don't get large fragments, but it is not good in very hard stones. This is an example for this technique, dancing technique. And you can see that the operator here makes use of the breathing of the patient as well to help him with the movement back and forth, and always on the periphery. So you just take layers of sand or dust off. Now, if you have very hard stones, you do a chipping technique. Again, your aim would be not to make large fragments, but to make small fragments of a maximum of 1 millimeter, which you can leave to be washed out. So the energy is directed at an eccentric focus at the edge of the stone, and that causes the stone to rotate. This is an example for the chipping technique. So the operator stays at the edge of the stone all the time. The stone turns a little bit around. Now people will say this is not a hard stone, and you're absolutely right. This is to demonstrate the technique. It is actually a soft stone. Now if you have a very hard stone, a brushite stone, a calcium oxalate monohydride stone, a cysteine stone, then you can use the fragmentation technique. So you aim your laser at the center of the stone, and the idea is to make holes into the stone, weaken it along its cleavage planes so that the stone splits into fragments, and then you have, of course, to attack each fragment again and do the same thing again until it becomes smaller and smaller. So this is an example of a hard stone, and it is indeed a hard stone. For those who are familiar with this, you can see this is a calcium oxalate monohydrate stone trapped in a stone cone, and you see that the stone doesn't break easily. You actually have to drill holes into the stone and then connect the holes, and then eventually the stone will break. And finally, we have the non-contact lithotripsy, which is also called popcorning or helicoptering. So the stones are in a confined space, which could be a calyx. They're pulverized, and if you do that, the stones, they jump around. So some stones will be hit by the laser directly, but some stones will hit each other and break further. Now, traditionally, we would use a high energy and a high frequency but it was found that that leads to a high burn back of the fiber. And who does, people who do this pulverization themselves, they will have noticed that the fiber gives up after 2-3 minutes of doing this. And sometimes you need to do this for 10 minutes. So more recently, it is said to, with the newer lasers and the more powerful lasers, to have a higher frequency and a lower energy. That was termed pop dusting. So that should reduce the burn back of your fiber. So you see here low energy, 20 Hertz, which is 10 watts. So the stone had been broken previously, and now the fragments will become smaller and smaller and smaller. So if you want to know if your fragments are small enough, as a point of reference, the laser fiber is 1/5 of a millimeter. So this will show you if the fragments are smaller than 1 millimeter. So to reduce the burn back of the laser fiber, recently people advocate a low power laser setting for different lithotripsy techniques. And if you can see here for the dancing technique, we have an energy of around 1 joule and a frequency of about 10. Same for the chipping. So both of them are on the periphery. The difference is one is a soft, the other one is a hard stone. For the fragmenting of very hard stones, you ramp the energy up and you keep the frequency fairly low. And for the popcorning, which we just have seen, you keep a reasonable low energy and high frequency. Now we're coming to laser safety. So you should have a key controlled device. So no key, no laser. People who use the laser should have suitable training. There must be a laser log. Which laser, what fiber was used on what patient, at what time, in what theater, what energy was delivered, how many laser shots were given. It goes without saying that maintenance and checks must be regular. The surgeons should ideally be trained. You should wear eye protection, and there should be signs on the door and ideally automatic locks. So when the surgeon activates the laser, the doors are locked. Now this gentleman is very familiar to you. And you can see here, although this is a urological laser, as you can see from the position, but it's not necessarily for stone disease. Now, tips and tricks: keep your instrument as straight as possible, reduce the bending of your laser fiber, and for that, if you can, if it's a deep lower pole stone, basket the stone to the upper pole. It may give you a better stone-free rate, and it's certainly safer for your scope. Pin your stone down. We all have experienced stones escaping us over and over again. It makes our life miserable. So you see here on the left side how I pin the stone against the wall of the calyx. Work around the outside of larger stone to minimize the fragments. And of course, it goes without saying, have always a good irrigation to clear debris and maintain a good vision. Now, always ensure your scope is straight before you insert the laser fiber. Remember the electron microscopic picture. The fiber is razor sharp. If you have the least resistance, make sure on X-ray to see that your scope is straight, not that you scratch around the corner. Have the laser on standby while the tip of the fiber is not visible outside the scope. Very important. Always be prepared when your laser goes back into the scope, put the laser on standby. It has happened to many of us. Yourself or somebody steps on the laser whilst the laser fiber is in the scope, your scope is gone. Now on your left side, you see something called a port seal, and I find this a very useful little device which locks the laser fiber in position whilst you're lasering. So that avoids actually the retraction of the laser fiber into the scope, and it avoids also when you're holding the laser fiber that you inadvertently move it inside the scope. Now, newer laser systems have now operator control lasering, which means you don't need necessarily somebody standing at the laser and say, stop the laser, stand by, change the energy to this, change the frequency to that. You will have your own pedal, just like for X-ray on professional X-ray tables. And you can switch from standby to ready, change the mode directly, and you can change the settings with the mode, of course. Now, this is what you don't want to see in a laser. This is a big oops in the fiber, but that's not so bad. This is more oops. This is really bad, because that means 15,000 US dollars down the drain. Now, of course, our laser fibers, if you have one in your hospital, they have a soft tissue mode. I'm not going into details of that, but there is a soft tissue mode, and they can be used for soft tissue ablation and coagulation. So the take-home messages here, laser is indispensable to a stone surgeon. I think there's no doubt about that. You should know your pros and cons of the fiber types. Safety of the laser should be paramount. Laser is not a toy. It's a serious tool. Safety of the patient, safety of yourself, safety of your staff, and safety of your kit, which is the expensive flexible scope. Now, know your laser settings. As dry as this talk may have been, but it is very important. You need to know your settings. And you should have more than one treatment option available for any stone. That means you should have a selection of fibers, a selection of settings, but you should also have, for example, a lithoclast on the side or an ultrasound probe, or you do what is shown here on the left side, you centrifuge the stone out. At the end of the day, the treatment should be patient-centered and custom-tailored for each stone and each patient. Now I will, now we have a little bit of problem with the sound here. I'll show you the video anyway without the sound. You will enjoy the video also without the sound. So don't try that at home. Laser is a serious tool, as I said. These are my references. And finally, I want to remind you of our experts in stone disease meeting, which was scheduled for June 21, after it was already postponed from January 21. Unfortunately, we will have to postpone it a bit further because of the COVID crisis. So stay tuned until we know when that will be. Thank you very much for your attention.
Yeah, thank you so much, Dr. Buchholz. I think an interesting talk with some insights, actually, especially I have never heard before. So there might be some questions from the audience. However, I don't see any question there. There is one coming. And so if okay for you, I will read the question and you try to answer them. There is the first question from Dr. Ashraf Ibrahim. He asked, for fragmentation, what is the wavelengths that should be used, long or short one, or vice versa for dusting?
Okay, so I presume that this is not the wavelengths, but the pulse lengths. The wavelengths, of course, is always fixed at 2,100 nanometer for holmium. The pulse length is the long pulse and the short pulse. Now, as we said, up to a total energy of 10 watts, which is joule times hertz, it doesn't really matter. But after that, there is much less retropulsion with a long pulse. Now, if you want to save your laser fiber, then a long pulse is, if you have a prolonged kind of lasering, then a long pulse is advisable.
Mm-hmm. So another question is, what are the ideal patients for a laser therapy? Is there something you can recommend?
The ideal patient would be any patient, that is debatable, but any patient with a stone anywhere in the kidney and ureter under 2 centimeters. I think we can still agree on that at the moment for the average urologist.
Okay, there's another question that is in the chat. What are the chances in popcorning that dense fragments can hit the lens and damage it? Or is there any risk?
No, it is not, because the lens is usually a little bit back into the scope, even if it's only a fraction of a millimeter. And it simply hasn't been reported. It hasn't been reported.
Another question also concerns the popcorning. What are the chances in popcorning that dense fragments can hit the lens? So
no, that we had just now.
That we had.
One doctor is asking, can you please briefly describe the procedure? This is for, because I know that some in the audience are not in theaters all the time. They may not know what a ureteroscopy is. So basically, we would put a flexible thin instrument with a diameter of about 3 millimeter all the way up the ureter into the kidney. And then this thin instrument has light diodes at the end. It has a channel for water, and it has a working channel where we can put the laser fiber through. The laser fiber itself, as I said, is 1/5 of a millimeter, and then we can work inside the kidney.
What type of laser settings are you using in PCNL?
Well, I don't use laser in PCNL if I don't have to. I used it a few times when the lithoclast wasn't working. Then I preferably take a larger fiber, and because the stones are big, then I would use a high energy and for example, energy of 15, 1.5 joule or 2 joule, and a frequency of between 8 and 10 hertz, because if you ramp the frequency up in these big stones, you will find that you don't see anymore because there's just too much dust floating around.
So your preference whether disposable or reusable probes is better or preferred from your side?
Well, that's another talk, if you give me another hour, but there's obviously advantages of disposable scopes, because every time you get a new scope, you get a perfect vision, you get a perfect bending scope, but there's the cost factor, right? Mm-hmm. And I found sometimes in difficult stones, although it is advisable to use a disposable scope, because if it breaks, it doesn't really matter. I switched to a conventional scope and got a better view in difficult cases. Sometimes that happens.
And regarding fibers, disposable or reusable?
Yeah, I prefer the disposable ones for the reasons I outlined in my talk. But of course, like here in Dubai, I'm going to different hospitals, so I use what I'm given.
Okay. Another question, is it necessary to ask the CT before advising laser treatment?
It is necessary these days, I think, for any stone treatment to have a CT scan, even if it's only an unenhanced CT scan. The EAU guidelines say you should also have a contrast study, but you can get away by doing a retrograde study at the beginning of the procedure. You may be in for some surprises in the ureter then, without knowing that beforehand. But yes, I think it should be standard procedure these days to have a CT scan.
Okay, next question, comparing the cost and also the blurring effect of high power laser. What are the real benefits of a higher power laser like 100, 120 watts laser with Moses effect? Probably compared to a low power laser.
Okay, that's a very good question. If you use the Moses effect with a high energy, then as I outlined in my slides, more of the energy will reach the stone. There is a chemical breakdown of the stone, so you get a quicker stone fragmentation, so you save surgery time. But of course, if you look at the overall operation that takes for an average stone, say 1 hour, the lasering time will be something like 15 minutes, the actual lasering time. So if you reduce that by 5 minutes, that may count in high volume centers where you do 10 operations a day, but if you do 2 or 3 operations a day, it doesn't really make a difference. That's my practical take on it.
Okay, I don't see any further questions coming. Probably that means your talk was
clear, hopefully.
Obviously, so there are no questions left. What could be the complications using the laser? I think this was already mentioned in your.
Yeah. Now, if you operate in a confined area, say inside the ureter, you need to make sure that you don't touch too much the mucosa. Even if you touch the mucosa is still very forgiving. But if you poke your laser deeper through the mucosa and induce scarring, then you may get a stricture after that. Same in the kidney. If you poke your laser too firmly and you slip off the stone, you may induce bleeding because you make a hole in the kidney. It doesn't really matter for the patient because the kidney, again, is forgiving and the hole will close. But if it starts bleeding, you simply don't see. So that's the problem, because our instruments are so fine, so small. Imagine 1/5 of a millimeter. So if you have 1 drop of blood in front of your lens, then you don't see anything, right? So that's a complication. The laser itself is fairly safe because, as I said, it has a penetration depth of only 1/2 a millimeter. So if you touch any part of the body, it will only go 1/2 a millimeter inside.
Okay, thank you. Dr. Ashraf is asking, sometimes during a fragmentation, the fiber got trapped into the center of the stone. And he's asking, should I continue the fragmentation or should I try to get the fiber out of the stone?
What you do is you keep shooting and try to get the fiber out. Now, if it's really trapped in the stone, and of course you shouldn't pull it back so that it sits right in front of your instrument, and when it becomes loose, whilst shooting, it goes back into your your instrument and shoots inside, then you have damaged your scope. So usually what happens is if you pull a little bit and you keep shooting with that, but without pulling it all the way into the instrument, then it becomes loose. Now, if it's a stone that's movable, then you might want to keep on lasering until the laser fiber is through the stone. Again, depends what's behind the stone. If you have space there, that's fine. But usually it is the laser fiber is able to be pulled out.
Okay, no more question from the audience. There's one more. So, okay, good. If you have a stricture before the stone, which is better for cutting, Trillium or holmium?
Okay, now Trillium lasers are not very widely available at the moment, right? Yeah. So it doesn't really matter because both work the same way. And if it's a small stricture, you just do one cut and you do it either with the holmium or with the Trillium. So the effect of the Trillium of being much faster in stone fragmentation is a bit lost in this case because it's only one cut. It may be different if you want to ablate a big tumor.
Yeah, logic makes sense. Yeah, let's wait a few seconds once the next question comes or pops up. If not, 1, 2, 3, then I think we are done. And yeah, for me, the opportunity to thank you very much for this fantastic talk. Yeah, there's still the possibility to ask you question by sending an email to your
Absolutely.
And yeah, let's say I think we answered all the question. I think it was very informative. You touched almost everything. This session is recorded, so if everyone wants to see it again, there will be a link provided, and ask your manager or your manager to provide this link. Zoom will provide it within the next couple of hours, and of course I will forward it to all the related persons in this webinar. Thank you again, Dr. And I thank you also my colleagues, Hisham and Domenico, for being here, and hope to see you again in the next weeks, years. And yeah, thanks again for this very informative webinar.
Well, thanks for giving me this opportunity, and I see there's a lot of friends on the audience. I see all the names, so have a good night and thanks for attending. And it was my absolute pleasure. And of course, I will meet all of you in person, hopefully, once this virus has been lasered successfully, if we can't vaccinate it. Thank you.
Absolutely.
Thanks a lot. Have a good
Bye-bye.
evening.
Bye-bye. Good evening.
Take care. Think positive. Stay